Hello, everyone. Welcome to the California Reducing Disparities Project Education, Outreach, and Awareness webinar series. So great to have you all here with us right before the holidays. And for those that are attending, thank you for attending. My name is Mihae Jung, and I am the Community Advocacy Director at California Pan Ethnic Health Network, CPEHN. I will be your facilitator today, and I'm also the CRDP lead here at CPEHN. So if you have any questions about the webinar or the education and outreach and awareness project, you can ask me. So thank you so much for joining the Education, Outreach, and Awareness webinar series. The CRDP monthly webinar series will provide tools necessary for you to elevate and highlight community needs, identify and explore mental health funding resources and opportunities, and innovatively tell your success stories to key stakeholders. So whether you're a community leader, an executive director at an organization, or a clinician, or you're running the implementation pilot project directly, we really hope that this webinar series will be a useful resource for all of you, your team, and also your community. So before I introduce the speaker today, here's a few housekeeping items. Please submit your questions via the question box. If it's not showing up, you may need to click the orange arrow to show the control panel. We'll address all the questions. We'll address questions one time after Adriana's presentation and another section after Carolina's presentation. So we'll have two different opportunities to have a dialogue. Today's webinar is being recorded. You can view the recording and the slides on the CPEHN website, and the recording will be available right after the webinar. Everything will be sent to you via email if you've registered for this webinar. We welcome you to revisit this content yourself and or share it with your colleagues after the recordings become available to you. Please take a moment at the end of the webinar to complete a quick evaluation survey. We value your feedback, which helps us measure our work and improve the EOA webinar series in the future. And when I refer EOA, that is Education, Outreach, and Awareness. So the webinar today is going to cover California's mental health funding streams and the systems that move money and power around. So I think this topic is going to be really relevant for many of you as you are, working towards sustaining your programs and working towards integrating your community-defined evidence practices with the mental health systems that exist in your county. So we hope this information is relevant to you and useful. And if you have any feedback, please let me know. So we're going to get started with Adriana. Adriana Ramos-Yamamoto joined the California Budget and Policy Center in February 2019. Her work focuses on health policy, specifically to increase access to and understanding of California's mental health system, and to contribute to the Budget Center's work on social determinants of health. Prior to joining the Budget Center, Adriana worked as a health policy associate at the Children's Partnership and as a graduate student intern and health educator at the Los Angeles County Department of Public Health for the Maternal, Child, and Adolescent Health Programs. Adriana received a master's degree in public health from the University of Southern California and her bachelor's degree in government from Claremont McKenna College. So we're really excited to have Adriana here with us, and she is going to be going over the California's mental health system. Take it away, Adriana.
Great. Thank you so much, Mihae, for the introduction, and thank you to CPEHN for inviting me to join you all on this webinar. I'm really excited to talk to you today. Today, I will provide a very high-level overview of the public mental health system in California And I also want to note that we are going to be publishing a longer, more comprehensive chart book early next year. So this is a great opportunity to share sort of a sneak preview into that. So please stay tuned for more on that. Next slide, please. Okay, so I will start by highlighting mental health disparities in California. I'll then talk about the entities that administer and oversee public mental health systems, how these services are delivered, how they're funded, and I will also talk about the recent funding trends. And also want to note, I'm talking about publicly funded mental health services that are provided in community settings, primarily through Medi-Cal. We're not talking about services provided through private insurance, for instance. And some publicly funded mental health services are also excluded today, such as school-based mental health services, services for children and youth in foster care, and services for incarcerated adults. So next slide. First, I want to go over some frequently used terms for mental health conditions. You might have seen these a lot already. The first one, mild to moderate, is not a clinical term. It's a Medi-Cal definition for adults. It doesn't really apply to children. Mild to moderate is a categorization for mental health conditions that result in mild to moderate distress or impairment of mental, emotional, or behavioral functioning. Serious emotional disturbance is a categorization for children and youth 17 and under who currently have, or at some point during the past year have had, a mental, behavioral, or emotional disorder resulting in functional impairment that substantially limits functioning in family, school, or community activities. And lastly, serious mental illness. This is a categorization for adults who currently have, or during the past year have had, a diagnosable mental, behavioral, or emotional disorder resulting in functional impairment that interferes with major life activities. Next slide, please. Okay, so I did want to also talk about some of the disparities that exist. Here we see serious mental illness is more common among adults living in poverty. So if you take a look on the left column, the rate for serious mental illness for adults living below 100% of the federal poverty line is 8.9%. And I should have noted the rate for all adults in California with serious mental illness is 4.2. So this is almost double that rate. Next slide. If you look at the breakdown by race ethnicity, you also see that serious mental illness is more common among adults for Native Americans, as well as Black, Californians, Californians with multiple races, and Latinx Californians. Next slide, please. Looking at children, this sort of reflects what we've seen in the breakdown for adults. Serious emotional disturbance is most common among children and youth in families living in poverty. The rate for all children in California is 7.6. So as you can see, if you look at the column on the left, for children living below 100% of the federal poverty line, that rate is higher. It's at 10%. Next slide, please. And looking at the breakdown by race ethnicity, we see that serious emotional disturbance is highest for Black, Latinx, Native American, and Pacific Islander children and youth, similar to what you saw in the adult breakdown. Next slide. Next slide. Okay, so switching gears to governance and oversight. We know that the state's public mental health system is governed by federal, state, and local entities. Next slide, please. So these are the entities at the various levels who have responsibility or governance. On the federal level, the Centers for Medicare and Medicaid Services oversees California's Medi-Cal program. The Substance Abuse and Mental Health Services Administration, SAMHSA, monitors the state's administration of block grant funding for mental health services. The Department of Healthcare Services, DHCS, oversees California's Medicaid program, as we all know is referred to as Medi-Cal. It also administers the Medi-Cal Specialty Mental Health Services program that I'll be talking about later on in this presentation. Established by Prop 63, the Mental Health Services Act in 2004, the Mental Health Services Oversight and Accountability Commission oversees MHSA programs and implementation. The California Behavioral Health Planning Council is mandated by federal and state statute to advocate for children with serious emotional disturbance and adults with serious mental illness. They also review and report on the public behavioral health system. They participate in statewide planning, and this council also advises the legislature on priority issues, so they also play a key role on the state level. And on the county level, the county boards of supervisors oversee local mental health programs with input from local mental health, or local behavioral health, I should say, advisory boards. And I also want to note before moving on that DHCS has a role in MHSA oversight and oversight at the local level as well. And also not reflected here, but the Department of Managed Healthcare and the California Department of Insurance has oversight on parity. I'm not going to be getting into parity for the purposes of this presentation, but I did want to mention that. Next slide. Okay, so the state's public mental health system provides services to many individuals who are experiencing a mental illness. Next slide. This is an illustrative overview of the state's public mental health system. Again, this is not an exhaustive list. As you can see, California counties are responsible for both Medi-Cal specialty mental health services and for safety net non-Medi-Cal community mental health services. And while counties have historically provided most Medi-Cal mental health services in the state through county mental health plans, some services are available on a fee-for-service basis if you look on the left. Other services have become available through Medi-Cal managed care health plans, also on the left. Since California expanded the scope of mental health benefits available to Medi-Cal beneficiaries in 2014 related to the implementation of the Affordable Care Act. The yellow arrow is just highlighting that there is coordination among these different delivery systems, and that coordination, as you all know, is a work in progress, and I won't say more on that. Next slide, please. So I'm going to be talking about these different systems. So as you saw in the earlier slide, Medi-Cal managed care plans and fee-for-service Medi-Cal provide mental health services to beneficiaries with mild to moderate mental health conditions. So 10.8 million Medi-Cal beneficiaries in all 58 California counties receive their health care through 6 main models of managed care. And among the mental health services provided are services that are within a primary care provider scope of practice, psychotherapy, psychological testing, and medication management. And just to note, in the fee-for-service delivery model, the state pays the healthcare provider for each administered state plan service, and in the managed care delivery system, typically the state pays a contracted health plan a fixed payment amount for each enrolled beneficiary. And managed care plans are then responsible for providing the delegated services. Next slide. Okay, so counties provide services for individuals experiencing a serious emotional disturbance or serious mental illness. Counties are responsible for Medi-Cal specialty mental health services, mental health services programs, and safety net mental health services. And I'm going to talk about each of these 3 different programs or systems in just a moment. But I wanted to note that counties deliver services through county-owned and operated facilities. Counties also contract with hospitals, clinics, private practitioners, etc., in order to deliver these services. Next slide. Okay, starting with specialty mental health services. These are carved out of the broader Medi-Cal program and are administered by DHCS under the 1915B waiver that is approved by Centers for Medicare and Medicaid Services. The department contracts with a mental health plan in each county to provide or arrange for the provision of Medi-Cal specialty mental health services. So Medi-Cal beneficiaries for adults have to meet certain medical necessity criteria. They would have a serious mental illness. Otherwise, they would be receiving services under the managed care for a mild to moderate condition. And this is different for children. Children's specialty mental health services are provided under the federal requirements of EPSDT benefit, the Early Periodic Screening, Diagnosis, and Treatment Benefit, which is available to full scope beneficiaries under age 21. And services in the Specialty Mental Health Services Program include therapy, crisis intervention and stabilization, psychiatric services, and day treatment and rehabilitation. Next slide. Okay, moving on to MHSA programs, which came about as a result of Prop 63 in 2004. As you're all familiar, Prop 63 created a 1% surtax on personal income above $1 million to provide increased funding for mental health services. And a small percentage of funding, 5%, stays at the state level. The majority goes to counties, and counties have some flexibility in how to use these funds. So the MHSA does specify 5 required components. So the first is community services and supports. This involves the funding of direct services to individuals with severe or serious mental illness, capital, facilities, and technological needs. This is for building projects and improvement of mental health services delivery by increasing technological capacity. Next, there's workforce education and training. This includes funding to improve the capacity of the mental health workforce, prevention and early intervention. This makes up 20% of MHSA funding for outreach programs for families and providers to recognize early signs of mental illness. And lastly, innovation. This involves the funding and evaluation of new approaches to increase access to underserved communities, promotion of interagency collaboration, and increasing the overall quality of mental health services. Next slide. Okay, counties also provide safety net mental health services to uninsured Californians with serious mental illness. These services are generally similar to Medi-Cal specialty mental health services and are provided to the extent that resources are available. So this is going to look different by county. The counties have to provide crisis services to all residents regardless of insurance status. So even those with private insurance, for instance, can receive crisis services through the safety net. Next slide. Okay, so moving on to funding. Funding for public mental health services comes from multiple sources. Next slide. Building on the illustration we saw in the earlier slide, and apologies, I know the formatting is a little bit off here. This is a general overview of California's public mental health system. As you can see, we have federal funds, state general funds, realignment funds, and MHSA funds flowing to Medi-Cal and to counties. Next slide. Here we have the funds listed out. At the federal level, California receives funding support through Medicaid and SAMHSA, the Community Mental Health Services Block Grant. The state provides funding support through 1991 and 2011 Realignment, which I'll talk a little bit more about in a short moment, as well as the MHSA and the General Fund. And counties also use their own funds to support mental health services through local property taxes, grants, and other sources of funding. Next slide. Okay, so on realignment, very briefly, realignment is the transfer of administrative and financial control from the state to counties. California underwent 2 major realignments in 1991 and in 2011 that affected mental health program responsibilities and funding. So prior to 1991, county mental health programs competed for limited funding made available through the annual state budget appropriations process. And in 1991, the legislature enacted a major realignment of health and social services programs and funding responsibilities. So state policymakers transferred several programs and responsibilities from the state to counties, changed the way state and county costs are shared for certain programs, transferred health and mental health service responsibilities and costs to counties, and increased the state sales tax rate and the vehicle license fee, and dedicated the revenues to counties to help support their new responsibilities. And in 2011, the remaining public mental health services were realigned, and this was known as the Public Safety Realignment. Essentially, a portion of revenues from the state sales tax was deposited in each county's behavioral health sub-account. So the 2011 realignment funding supports the specifically Medi-Cal specialty mental health services. And before I move on, one last policy I should also note is Prop 30, which you all may be familiar with, passed in 2012. Prop 30 added constitutional protections to the 2011 realignment funding structure. It also prohibits the state from passing any new laws, regulations, or administrative orders that increase county costs without providing additional funding. So while most of the funding, as you'll see in the later slides, comes from 1991, 2011 realignment, MHSA, and federal funds, we still see some funds coming from the general fund, mainly due to Prop 30. Next slide, please. Okay, so for the purposes of the rest of the presentation, we're only going to be talking about these specific funds. Next slide. Okay, so this is an overview of funding for county-provided mental health services, which, as you can see, primarily comes from the state. So on the first slice here, you have $2.8 billion from 1991 and 2011 realignment combined. You also see $2 billion from the MHSA, as we know, is Prop 63 funding. You'll also see a small slice coming from SAMHSA, the Community Mental Health Services Block Grant, and roughly $3 billion from federal funding through Medicaid. Next slide. Okay, so funding for California's public mental health services has increased in recent years. Next slide. So this is showing you that increase. So public mental health funding in California has increased by roughly 35% from 2012, from the fiscal year 2012-13 to this most recent fiscal year 2019-2020. And while this is reflective of only some of the funds that I had mentioned earlier a couple of slides ago, there's a question of, I think, is funding for mental health services keeping pace with the need for mental health services? Is this funding enough to meet that need? And so I'll sort of leave you on that to think about, and maybe Carolina might add on to that a little bit during her parts of the presentation. So next slide. Okay, so with that, I will pause for now, see if anybody has any immediate questions. But I want to thank CPEHN again for inviting us to participate in this webinar. Thank you.
Thank you, Adriana. So I am seeing if we have questions flowing in. Have two questions that are more like logistical. How do you get audio on? So Christina, you might want to dial the, there should be a dial number if you expand the audio box. So you can try that out, and you can just send another message if you are not able to get on. When will the recording of this call be sent out? We're going to do our best to try to do that today, because I know a lot of folks are going away for the holidays and we don't want you to wait that long to have the recording. So we're going to try our best to do that. And also the recording will be available on the CPEHN website as soon as we are done recording it. So it will be all available to you soon. There's a question. It says, was 35% increase from federal or MHSA? So Adriana, did you want to take that? So the question is, was 35% increase from federal or MHSA?
Oh, that's a really great question. So if you go back to that trend, the trend is showing an aggregate from MHSA federal funds, as well as, sorry, can you go back to the previous slide? Okay, so yeah, it doesn't show a breakdown of the increase per funding, but I'm happy to follow up with you on that. We do have that information broken out by federal funds, by state general funds, by federal MHSA funds. So happy to follow up with you if you send me your contact information, or if Mihae, you can connect us following this presentation. I'm happy to share that more detailed information about that with you.
Great. There's another question. Very good presentation, Adriana. Are you involved at all with DHCS CalAIM's restructuring efforts? Actually, when you answer that, Adriana, if you don't mind just briefly explaining CalAIMs, because there's going to be folks that have not heard that terminology before. So if you can just demystify that, that would be great.
Sorry, I had realized I was muting myself. Okay, yeah, great question. And you know what? I did mean to, in my overview, mention that these services are currently structured in this way. And yes, given the initiative, the CalAIM proposal, that is going to be changing. So CalAIM is an initiative by DHCS to improve health outcomes by systems change. And there's going to be some payment reform as well. I think the idea is to move more towards a whole person care approach and addressing the social determinants of health. So yeah, there will be some systems changes and payment reform changes, specifically through the 2 Medi-Cal waivers. The 1915B waiver, which I talked a little bit about during the presentation, that's a specialty mental health services waiver, as well as the 1115 waiver. So that's, I think, as far as I can go in terms of demystifying that a little bit. Maybe Carolina can expand a little bit more on that. So big structural changes to happen over the next year, I believe. You can correct me if I'm wrong. We're going through those waiver renewals. Oh, and actually, I meant to answer the second part of your question, is if we are involved on that. We're not on any of the stakeholder work groups or anything. Several members of our board are and are really in tune with some of the changes happening there. So we are just following along with many of you.
Thank you, Adriana. There's actually another question. It says, how will, actually, let me see here. There's another comment. I think it's a comment. As it happens, there is a Department of Healthcare Services Behavioral Health Work Group meeting today from 10 to 3. It would be great to know you're part of these conversations. We need advocates for diverse populations who understand these systems to be at the table, and you strike me as being a good candidate for that.
Oh, thank you. I really appreciate that. I actually didn't know there was a committee meeting today, so thank you so much for the heads up, and definitely we'll try to tune into these conversations happening again, along with many of you on the line.
Great. There is another question here. How will the young adult expansion impact access to mental health services? So I'm assuming this has to do with the Medi-Cal expansion to young adults that will be implemented soon.
Right. And you know what? I might defer to Carolina on that, but generally I want to say that they will have access to these behavioral health services that that prior to this young adult expansion they did not. That's actually all I should probably say on that, and defer to Carolina to see if she can expand more on that. But that's a great question.
Awesome. Okay, so there's another comment. All questions and responses submitted regarding the webinar should be shared in writing to the entire CRDP Hub, which, yes, we are happy to do that so that people have all the information that they need. Okay. Also, there's another comment. Here's a link to the website for the Behavioral Health Work Group page. And then Lillian, thank you, Lillian, for the link. And so we'll also include that.
Thank you again for that.
And Adriana is located in Sacramento, right? So it's really helpful to be able to do this work in Sacramento. Okay,
right.
so
contact information is there. So happy to connect with you offline following this presentation to stay more engaged and in tune with some of these changes happening to our public mental health delivery system. So thank you so much for your great comments and great questions. And if I didn't answer one of the questions in more detail, please just reach out to me and I can provide that information to you.
Great. Thank you so much, Adriana. And there's time to ask more questions at the end of the webinar after Carolina goes. And so I would like you to keep thinking about questions to ask. This is safe space for all of us, and we're all learning this information together. So, you know, keep coming up with questions. So we're going to actually move forward to the next presentation. Many of you have worked with her before. She's my colleague, Carolina, working at CPEHN. So Carolina Valle holds an MSW from the University of Southern California and a BA in Black Studies and History from University of California, Santa Barbara. Carolina brings a unique mix of expertise in mental health advocacy, consumer-driven policy analysis, and intensive case management experience to CPEHN. Prior to joining CPEHN, Carolina worked as a resource coordinator and maternal and child health access, where she was a lead advocate for high-risk pregnant and postpartum women dependent on the county mental health system. Carolina also served on the coordinating committee for the Los Angeles County Prenatal and Early Childhood Home Visitation Consortium. During her tenure, Carolina emerged as a regional expert on the barriers to utilization of mental health benefits for communities of color in Los Angeles County. Carolina is a graduate fellow of UC Davis's Infant Parent Mental Health Fellowship Program. So take it away, Carolina. Thank you.
Thanks, Mihae, and thank you everyone for joining the webinar today. I am really excited to be here with all of you virtually to do sort of an introduction to some of the implementation challenges with funding. So Adriana provided a really excellent overview of many of the funding sources here in California and at the local level. And really what I hope to do today is discuss some of the limitations with those funding opportunities, some of the implementation challenges that we see on the ground at the local level, as well as some of the limitations of the oversight entities that are responsible for distributing these funds. So thank you. Next slide. So Oh, I was just talking about this. So these are the 3 goals of the presentation today. So we'll be reviewing limitations of oversight entities, providing a high-level overview of funding limitations, and discuss some of the implementation challenges. Next slide. So this is a sketch of our mental health oversight structure here in California. And a couple things that I want to point out to you on this slide. If there is one thing that you take away from this presentation today, it's that the Department of Healthcare Services is the primary oversight entity for the distribution of funding sources to our county mental health systems. And the reason I'm pointing that out to you today is because, as you can see, there are many state agencies here in California that provide oversight to mental health services. We have DHCS, which provides oversight to counties and Medi-Cal managed care plans. So Adriana talked about the specialty mental health services, the MHSA services that are at the county level. Those are overseen by DHCS. She also talked about the mild to moderate mental health services that came into effect a few years ago as a result of the Affordable Care Act, and those are the responsibility of Medi-Cal managed care plans. Both of those entities provide different types of mental health services, and both of those entities are overseen by DHCS. We also have the Department of Public Health that has a portion of prevention and early intervention funds that it allocates to the Office of Health Equity that allocates those dollars to our community-defined evidence practice and programs that are on the call today. And then third, we also have, if you look to the right, the Mental Health Services Oversight and Accountability Commission, and they oversee the Mental Health Services Act, in particular our prevention and early intervention dollars. And they also oversee our stakeholder advocacy contracts. So they are, in essence, providing funds to community-based organizations interested in doing advocacy. And so when you're looking at this slide, it looks like there's an even distribution between DPH, DHCS, and the OAC. But what you can see here on the slide is a little money bag sign next to DHCS. And the reason why we put that there is because if there's anything that you take away from this presentation, it's that DHCS oversees funding. So that's really important when we think about where to dedicate our advocacy resources, and when we want to have conversations about funding, we really should think strategically about investing some of those energies into DHCS. So while the Mental Health Services Oversight and Accountability Commission does provide oversight to counties and stakeholder contracts, in particular on prevention and early intervention dollars, they do not control the purse strings. The Department of Healthcare Services does. Okay? Next slide. So I'm going to talk about these 4 big funding sources here in California. Adriana did an excellent job providing a high-level overview of each of these funding sources, but I'm going to talk a little bit about some of the challenges that we see on the ground and some of the limitations of these funding sources. So that's Medi-Cal, Realignment, the Mental Health Services Act, and then the Medi-Cal expansion that happened as a result of the Affordable Care Act. And in that slide, I will talk a little bit about the young adult expansion that's happening here in California to answer an earlier question from somebody. Next slide. Okay, so Medi-Cal. So Medi-Cal, as Adriana discussed, makes specialty mental health services for people who have serious mental illness an entitlement program. An entitlement program is a program that people have a right to. So what that means is if you have serious mental illness here in California, California law says that you are entitled to specialty mental health services. Okay. There are a couple of limitations with this funding source. One of them, as many of you know, is if you're not eligible for Medi-Cal, you don't have access to Medi-Cal and its specialty mental health benefit. Okay. And so we've seen a lot of progress here in California with the expansion of Medi-Cal to children, more recently to young adults, but we still have a large population in California between the ages of 25 and 25 and up that do not have access to Medi-Cal and therefore are not entitled to specialty mental health services through Medi-Cal. Sometimes what we hear from our partners in terms of the impact of this is counties may be a little bit more conservative with how they deliver services to people who fall short of the specialty mental health entitlement criteria. So what that means is that sometimes counties may not prioritize people that do not have serious mental illness, maybe people that are showing earlier signs but have not received a diagnosis, maybe people who need prevention services. And so counties oftentimes will really focus on ensuring that they are providing services to people that are entitled to it through this specialty mental health benefit. And so that's a little bit problematic because we know that here in California, only about 4% of Californians actually have a serious mental illness, and many, many more people have more mild, moderate preventative conditions that we really need to meet. And so you can hear this in counties. People will say, well, you know, my client doesn't have a diagnosis, but they still need mental health services. The counties told me I had to go to another organization for this. And that's oftentimes because counties can be a little bit preoccupied with meeting their entitlement statute. So related to this is a cost-based reimbursement structure that we have in our mental health system. So this is just some fancy terminology for how counties are paid. Essentially, just to put it in kind of basic terms, counties need to pay out of pocket, and then they need to submit their receipts to the state to get reimbursed for services. And so sometimes what that means is that counties can be conservative with how they use their dollars because they are having to essentially front the money before getting paid by the state. Okay. Next slide. So realignment. So this was talked a little bit earlier in Adriana's presentation about what realignment was. And just briefly, I will say that realignment shifted responsibility of many mental health programs, as well as other safety net programs, including child welfare, IHHS, CalWORKS, low-income healthcare programs. It shifted the responsibility of those programs from the state to the counties. And it also increased funds to the counties who are now expected to provide the range of services that were realigned. And then the third thing that realignment did was it actually recognized that people who are uninsured are also should also receive services. And so realignment said that counties are able to provide mental health services to people who don't have access to Medi-Cal, but so long as those resources are available. So it added a particular clause in that funding source to say, if we run out of realignment dollars, we are not required to provide those services to people who are uninsured or don't have access to Medi-Cal because of their immigration status. So that's a problem. We hear a huge rise in mental health needs among certain populations, among the uninsured, among our undocked population. And so, if counties can oftentimes tell us that they don't have their realignment dollars or they've run out of those realignment dollars and therefore cannot serve that population. So counties use these funds a little bit differently. Today, the funds are diminishing. In fact, there was a report last year by the state legislature which found that the funds are diminishing. The way that the funding is allocated is very complicated because so many program needs are being met through realignment. So there's some discussion right now at the state level about whether there's a need to really shift the realignment funding formula and make it updated. So next slide. So the Mental Health Services Act. So, Mental Health Services Act, as you know, really expanded funding for our mental health services here in California. It put into statute a commitment to serving communities of color, underserved populations, and very importantly, it's actually one of the few places in our state laws that recognizes the importance of community-defined practices. So that's really important to note since we have so many people on the call today that are really pioneering this work and see a lot of alignment with what they're doing and the Mental Health Services Act. So it really laid out a vision to support underserved populations. As Adriana discussed, it is a millionaire's tax as well, so that is really the main source of funding for this act. Some problems with this funding source. So it is a funding source only. It is not an entitlement program. So it's a little bit different than our Medi-Cal program, which states people are entitled to services if they have serious mental illness. In contrast, the Mental Health Services Act does not entitle people to mental health services. It primarily invests funding into certain types of programs, including prevention and early intervention, workforce, capital development, and so on. Another really big challenge with this funding source is that we just haven't seen strong oversight from the Mental Health Services Oversight and Accountability Commission. We've heard from a lot of stakeholders that they just have not been maximizing their authorities. And so this is a really important consideration when we think about what they have the authority to actually do compared to, say, the Department of Healthcare Services that has actual control over the distribution of funds and really can play a critical role in how we provide oversight to funding in particular. So, really want to emphasize that point because I know there's been a lot of excellent work with the OAC and a lot of progress made with them. But when we think about investing some of our strategies and our resources into advocacy, we want to distribute it certainly to people that have control over the purse strings. Next slide. Okay, so Medi-Cal expansion. So this is referring to the Affordable Care Act, which expanded mental health benefits to people who have mild to moderate conditions. And it also assigned this particular responsibility to Medi-Cal managed care plans. So that includes, you might have plans in your community that you're familiar with, but some that just I can ring off the top of my head include Blue Cross, Kaiser, LA Care, HealthNet, Partnership. These are all plans. Every single county has different plans, but every single plan is responsible for providing mild to moderate mental health services. Some problems with this funding source. So we've heard from community partners that there is a huge lack of knowledge about this benefit. People don't know that plans are responsible for providing mental health services. And as a result, we're seeing really low utilization in communities of color for this benefit. And then third is managed care plans are not required by law to partner with community-based organizations who oftentimes have an expertise in providing more mild to moderate mental health services. Unlike our county mental health system, where we see a really robust network of community-based organizations that contract with counties, managed care plans do not have a strong history of partnering with community-based organizations. And so this is something to think about when we want to consider options for sustainability. So next slide. So just looking here again, just wanted to sort of emphasize the point that DHCS is responsible for overseeing the distribution of all these funds that were discussed in previous slides. Next slide. All right, so just a few kind of upcoming opportunities that we've heard about as it relates to these different funding sources. Some advocacy pressure points. So I think there was some discussion earlier during Adriana's presentation about CalAIM, and CalAIM is a really great place for advocates to plug into when we want to advocate for changes in our Medi-Cal mental health program. So if you're looking here at the orange slide at the bottom, it says CalAIM. So currently, as was discussed earlier, there are behavioral health work groups that are happening in Sacramento discussing reforms to the way our Medi-Cal mental health system is structured. One of the proposals actually relates to a problem that was discussed earlier about the payment structure with Medi-Cal mental health. DHCS is proposing that we improve the way counties are paid for mental health services. So as was discussed earlier, counties must deliver the service and then send their receipts to the state for reimbursement. So DHCS through the CalAIM waiver is proposing changes to this cost reimbursement methodologies to make it easier and more flexible for counties to provide services without being concerned about reimbursement. So if all of you are interested in getting plugged into this opportunity, please connect with us at CPEHN. We can also connect you with other state organizations that are actually seated at the table. Unfortunately, DHCS has been very selective and exclusive with who can participate in the behavioral health work groups. So our recommendation is that you partner with people who are in the work groups and funnel your questions to them and put the pressure on them and those organizations to lift up any concerns that you have about our Medi-Cal mental health program in those work groups. Those work groups will be happening from now until February. And then you can also actually, just one last point about this, you can also send your comments to the CalAIM inbox, even if you can't coordinate with anyone in a behavioral health work group or attend in person. Certainly that's very cumbersome to come to Sacramento, but you can also send your comments to the CalAIM inbox. So please let us know if you'd like that information, and we'd be happy to send it out. So realignment, one really important advocacy pressure point is the county budget process. So getting connected with your local mental health commissions and asking them about how they're using their realignment dollars and if they're prioritizing communities of color and prevention and early intervention, really, really important. In fact, we saw some work in Alameda County that wanted to realign some additional services for the incarcerated population, which they were able to successfully do. So it is possible to do some county level change with realignment through the state budget process. And we'd be happy to send out information about how Alameda did that or connect you with them if you're interested in getting in on the realignment conversations. The Mental Health Services Act, so lots of discussion and conversation about how the Mental Health Services Act dollars are being allocated. In fact, next year there is some discussion about a possible ballot initiative on MHSA that really looks at creating investments for particular populations, homelessness, youth, and I believe there's a third population that I can't recall off the top of my head. But again, if you're interested in following that conversation and advocating for the needs of your CDEP, this would be a great place to do that and see if, and we can connect you with the people that are interested in doing this work. And then the Medi-Cal expansion. So we're seeing, Medi-Cal being expanded to many populations, including our young adults here in California. We're also seeing some changes to the way that Medi-Cal managed care plans are delivering their services. So next year, there will actually be a whole discussion at the state level about contracts, Medi-Cal contracts. And so, as we discussed earlier, managed care plans are actually not required to partner with community-based organizations in their contracts. But if this is something that you think would be really important in your community and you want to work with your plan to do that and have them put a requirement in their contract that says they are required to partner with you, this has been done before. You can do it. We can connect you with organizations that have done it. But one really great opportunity that's coming up at the state level is the procurement process. Procurement is just a fancy word for contracts. So if you're interested in getting in on the conversation to advocate for managed care plans to partner with your CBO, getting involved in the 2020 procurement process is a great place to do that. And I think that's it. Next slide. So here are just some links for folks that are doing work on this area. If you want to get connected with any of them, please let us know, and we'd be happy to send out that information as well.
Great. Thank you so much, Carolina. So we have a few more minutes for Q&A, so I'm just going to open the floor for any questions for Carolina's presentation. Usually takes a few minutes for people to round up their questions. So in the meantime, I want to give a quick shout out to our presenters today. Carolina, that was really helpful information, really digestible, and I appreciate it. I appreciate that you included some of the implementation challenges because our partners, you know, it's the reality for a lot of us, and so for me, that was just very illuminating and also validating to hear that there are challenges. So there is a question, which I don't know. Do you believe there will be legislation introduced this year to amend Prop 63/MHSA?
Oh, that's a really good question. I am personally not aware of any legislation that will be introduced next year to amend Prop 63 or MHSA. Yeah, I don't know, but certainly if we do get wind of that, we would certainly want to communicate that back out. Yeah. Thank you. That's a great question.
Okay, so there's a question that's also being submitted. And yes, at CPEHN, we do monitoring of mental health related legislation. And this year, we're really excited to work very closely with Stacy at REMCO, combining our efforts to keep a pretty, you know, vigilant eye so that we are looking at, you know, we're keeping track of legislation that impacts communities of color. So really excited to join our forces so that, you know, we are giving you valuable information that you need to protect the services in the community that you serve. Okay, so here is a question. Okay. So there's a question. Could you say a little bit more about the process to address the procurement procedures?
Yes, thank you. Excellent question. We are not actually, we're monitoring. This is one of the things that we are also monitoring. DHCS has said that they will be issuing the request for proposals sometime in 2020, but they have not given a timeline. However, the procurement process must happen after the CalAIM discussions. So the procurement process, which is the discussion about contracts and what goes into contracts, needs to happen after the discussions about how to change our Medi-Cal system, which is what the CalAIM proposal is focused on. And that's because anything that comes out of CalAIM must then be put into the contracts, into the procurement process. So if I were to use my own sort of judgment, we know that the CalAIM process will be concluding in February. DHCS will likely release their final proposal, CalAIM proposal, sometime in the spring. So we can expect discussions about the procurement process, about the contract process to happen either sometime during the spring or after springtime, so summer or fall. And we will actually keep you posted on when those conversations start, because oftentimes they can happen really quickly, and you might hear it through the grapevine, through someone in Sacramento. So yeah, I hope that answers the question. But if there's any follow-up questions, please feel free to connect with me or with Mihae, and we would be happy to talk further.
Okay, so there's a couple more questions. One is, thank you so much for a very good and informative presentation, Carolina. At the beginning of today's DHCS Behavioral Health Workgroup meeting, they started at 10. It was stated that they had conducted stakeholder engagement. Do you know anything about that, and if there were efforts to include diverse communities?
Yeah, I'm so glad that we're getting this rapid fire information from the meeting today. So DHCS said, it looks like DHCS said that they conducted stakeholder engagement at the start of the meeting today, and to our knowledge, we are not aware of any stakeholder engagement they are referring to. So we would certainly have some questions about the extent and quality of the stakeholder engagement. DHCS did release a proposal and ask for comments from community-based organizations earlier this fall, and comments to DHCS were submitted by December 16th. So it's possible that they are referring to the comments that were submitted by community-based organizations by the 16th as their catch-all for stakeholder engagement.
Great. Thank you. And then there's another question. Don't know if this was covered, but since realignment happened twice in years ending in one, will that be expected in 2021?
That's a really good question, and I am not aware of any new realignment laws or changes that will happening in 2021, but I really like that thinking and appreciate the flag, because it may be the reason why it was passed again in 2011. So thank you so much for flagging that, and we can see if that's going to happen and get back to everyone who joined the call today.
Mm-hmm. And there's a couple more comments. I want to make sure everyone's input has been addressed. But I think this is a comment. That question may be a reference to that hearing last week where Steinberg stated he would like to see Prop 63 revised to focus exclusively on homelessness, formerly incarcerated youth in school or foster care. So I think that was a comment for... I don't know if Liliana, I am representing you correctly, but I don't know, Carolina, if you,
Yeah, I think excellent comment. I think that was in reference to the earlier question about whether there was going to be any legislation on MHSA Prop 63 next year. Yeah, so we're not aware of any legislation, but we are aware of a ballot initiative that's being discussed on that subject, so thank you.
Gotcha. Thank you, Carolina. And there's another comment that says, excellent presentations. And there is another comment, yes, the hearing by Assembly Member Rambula and Steinberg was the first speaker. Okay, that makes a lot of sense. Okay, so it is 12:03. So thank you for all folks that have joined the webinar today. And again, if you have any questions about Adriana's slides, you can contact me, and I'm happy to get you in contact with Adriana. If you have questions about the advocacy pressures and information that Carolina presented, you can feel free to connect directly with her, or you can always, contact me and I'll get you connected with Carolina. But this is a continued conversations, right? This is just the beginning, and that we're all looking at this system together, and so that the system works for communities of color and LGBTQ population, because now we're the majority of California and the disparities is still continuing. So it's really important that we all work on this together, and we're all deeply committed to moving this dial forward. So thank you everyone for joining the webinar. We will see you next month. Happy holidays.